Vi prego di prendere posizione. Austin non lo vedo. È qua, perfetto. Caterina, Monica. Boh, iniziamo intanto. Per comodità, scusate, mi siedo. Queste cose sono già state dette. Sono già state dette, quindi noi dobbiamo identificare e distinguere questi tre tipi di difetti all'inizio del travaglio. Meccanismi di difesa, concetto che spero sia passato ampiamente. Ritornando al discorso che faceva Monica prima per quanto riguarda il tipo di decelerazioni, la risposta è diversa in rapporto che noi abbiamo un feto che è ipossemico all'inizio rispetto a un feto che è normosemico all'inizio. Quindi questo è un dato da tenere bene in considerazione nel timing e decisione per il parto. Questo è l'algoritmo che è stato proposto dai colleghi del St. George's per quanto riguarda la gestione in relazione al pattern cardiotocografico, cioè di ipossia acuta, subacuta o a sviluppo progressivo. Quindi la gestione non sempre prende in considerazione l'espletamento immediato del parto, ma la prende in considerazione, quando ci sono le condizioni permittenti, previa valutazione e utilizzo di misure adiuvanti. Tutte queste cose le troverete comunque sul libretto. L'altra cosa che I would like to ask to Austin, I found this type of CTG interpretation in the second stage. I think, are you using this type of classification in your setting?
Our classification is the same, both first and second stage. But we are aware that in second stage things are a bit more difficult both for the baby and for the mother. But in terms of interpretation, it is similar.
Ok. Questa è una somma sostanzialmente, sapete benissimo che le classificazioni della CTG nel secondo stadio, le linee guida non fanno una distinzione primo e secondo stadio, e quella di Picard che si basa su 82 casi, di cui quei 2B e 3 sono, mi pare, 5-10 casi, e viene propinato ad ogni corso di CTG, non so Federico se mi confermi questo dato, viene propinato ad ogni corso di CTG come la risoluzione di tutti i quadri. A mio modesto modo di vedere ha una valenza che è limitata, anche perché la maggior parte dei tracciati sono poco classificabili e inquadrabili nelle classificazioni che ci sono. Allora, premessa, siccome già le altre volte è successo, qua bisogna intervenire prima, eccetera, eccetera, allora, questi sono tracciati che vengono discussi a scopo didattico, va bene? Quindi a scopo di discussione, va bene? Vi prego di astenervi da commenti o da quant'altro, ok? Questo è, allora, nullipara, nullip, rottura delle membrane minore di 12 ore, che entra con travaglio iniziale e con liquido tinto grado 1. Il travaglio viene indotto. Qui abbiamo utilizzato lo STAN, ma per il corso non faremo riferimento alla lettura STAN, ma alla lettura solo del tracciato. E quindi io lo scorro per sentire cosa mi dite. Quindi voi mi bloccate, vi prego, siccome ha senso avere una discussione interattiva, per il liquido tinto. Vado avanti? Nullipara, 39 settimane, sacco rotto, rottura spontanea delle membrane, liquido tinto grado 1. Basso rischio. De nuovo. Per il liquido tinto il collega ha pensato di indurre. Non era noto questo dato. Scusate, adesso si impianta. No, qua. Ok. Questo è il tracciato. Ricordo, allora di fatto è iniziata un'infusione ossitossica, 10 unità in 500. Prego. Abbiamo fatto, sì, con l'inizio dell'ossitocina, sì, sì. 10 unità in 500 da 3 ml, quindi 1.000 unità minuto. Possiamo, scusi, mi fa una cortesia, si passa il microfono perché... Dicevi, scusa?
Buongiorno, visto che ha iniziato l'ossitocina e ha già un'attività contrattile, mi sembra abbastanza importante, quindi mi sembra 3-4 oltre in 10 minuti. E si è pensato a un'idratazione?
No, di fatto non si è pensato all'idratazione.
Ok.
Tracciato normale, siamo d'accordo? Austin, if you have any comment, please.
I think if I understood
The case.
the first slide,
Yeah.
the woman is 39 weeks. Is that right?
Yeah.
Okay. At 39 weeks, I would expect the baseline heart rate to be a bit lower than it is. So what I'm looking at looks approximately 150, 155. And it clearly has some decelerations. Therefore, if this is the first CTG monitoring during the labor, the question I will be asking is this an evolving process, or is this a process that has happened before and the baby is recovering? But the association of baseline heart rate of about 150, 155 at term associated with decelerations during uterine activity tells me that something is going on. At this point in time, I don't know what it is, but clearly this is not normal.
It's not normal. Avete capito? Cioè, secondo lui, quello che sta dicendo è il fatto, linea di base, questa decelerazione, lui non sa se di fatto questo è un processo che sta evolvendo o se è un processo antecedente. Anyway, we carry on. Do you agree about that?
Yeah.
Comunque andiamo...
Can I ask something? Also, would you induce with a MAC1? Or would you just wait?
I try not to make too much distinction between the grades of meconium, because once meconium is present in the amniotic fluid, it contaminates the amniotic fluid in a way that, number one, degrades the ability of the amniotic fluid to continue to maintain its antibacterial activity. So those babies are quite prone to infection, number one. Number two, a significant proportion of babies will pass meconium because they're infected already. So those situations where you have ascending microorganisms into the amniotic cavity and then the baby swallows it and it sets up a gastroenteritis type picture and then they discharge meconium. So you and I may see meconium as light, not light, but actually qualitatively once it's present within the amniotic fluid, it does exert other pathological processes. So apart from vasospasm of uteroplacental vessels, you have this interference with the ability of the amniotic fluid to continue to maintain antibacterial activity. Those two put together, begins to escalate the risk for the baby. Whether it's thin meconium or thick meconium, the presence of meconium is a risk factor. So from a clinical perspective, particularly the CTG is not normal. I don't make that distinction between thick meconium and thin meconium. I think it's a bit casual, the way some guidance say thin meconium, don't worry, thick meconium, do something else. That's not how we practice in my institution.
Quindi a te...
The other question, if I can ask, would you do an FPS on this trace?
No, and that is because the variability is completely normal. So at this point, if you did fetal blood sample, the baby will be normoxic. But that doesn't mean that this baby is not at risk, is what I'm saying. Exactly, yes.
Chiaro il concetto, quindi indipendentemente dal colore, dal liquido, il fatto che ci sia un liquido tinto è un indice di sospetto. Quindi alla signora progressivamente è stata aumentata l'infusione ossitocica e alle 10 il reperto era molto iniziale perché era pervio al dito, senza scolo di liquido amniotico. Avanti? Siamo d'accordo, no?
There is some sort of cycling here, so this is a good sign.
Se qualcuno ha qualche osservazione mi blocca, va bene? Contrazioni sono 4-5 in 10. So this type of pattern, as for the variability,
Yeah.
is suspicious, normal, is nothing particular?
In the first stage of labor, if it's transient, nothing particular.
Vi ricordo che questo non è da cardiografo esterno, ma da scalpo. Allora, alle 12 siamo pervia 2 centimetri. Non ancora appianata. No.
Ma lo stan sul liquido tinto viene messo
Prego?
lo stan, l'elettrodo col liquido tinto viene comunque
Le controindicazioni allo STAN sono infezione conclamata in atto, lesione o epatiti o HIV. Ma non è questo l'oggetto del corso, scusatemi. If you have any comment, please, Austin, stop.
Dove c'è quell'innalzamento ancora un po' di più, c'è un innalzamento della linea di base, però torna indietro ancora. Eccola qua, questa non è una cosa ne pensa?
What do you think about this temporary increase of baseline?
If it's temporarily, then it makes very little difference, particularly if you don't have antecedent and sustained intermittent decelerations. That happens. At other times, the baseline may wander down and then come back up again. It's not associated with any specific abnormality.
Il fatto è temporaneo, non ha alcun significato clinico.
Credo che questo sia proprio un concetto fondamentale, tutto quello che è temporaneo nel tracciato e che ritorna alla normalità non va preso seriamente.
Usate il microfono. Monica sta dicendo che tutto quello che è temporaneo giustamente deve essere preso come tale e non come patologico, no? C'è il discorso del ritorno alla norma. Nel frattempo mi sono dimenticato di dirvi che la signora ha fatto comunque non ha fatto una peridurale. Il primo carico è stato somministrato alle 11 circa. Is in an epidural. The lady is on epidural.
Okay.
comment on that, Austin?
My concern here will be the baby seem unable to maintain a stable baseline heart rate. And that in itself may be problematic. But again, if you ask the basic question, is this baby hypoxic at this point? The firm answer is no, it isn't. But you then have to reflect on, well, why isn't the baby maintaining a reasonably stable baseline heart rate? That's a much bigger question. That's a much bigger question. And I suspect whatever the reason is may be linked to the advancement of labor, plus whatever it is that was responsible for that initial.
So are you saying that there is an instability of baseline?
Yes. So if you look in the period between 1345 to about 1405, and I don't know what's happened. You know, there's this sort of wandering in the baseline. In the definition of a normal CTG, one of the things I insist on is that the baseline has to be stable. So even if there's a deceleration, the baby returns to that baseline. If there's an acceleration, it returns to that baseline. Now, if you end up with a situation where the baseline is wandering all over the place, that in itself suggests a degree of cardiovascular instability. Sometimes babies do that as a matter of, transient phenomenon. But if it lasts longer than 10 minutes, the chances are, there's something else operating in the background.
So anyway, from the practical point of view, you carry on with this trace, but
I'll be
a little bit worried about
my alarm bells will be
because of instability of the baseline, isn't it?
Correct. Yeah.
Quindi il fatto che la linea di base sia instabile è un indice di sospetto, però non tale da. So in this case, do you suggest to use adjuvant measures for improving the CTG trace, such as hydration, or stop the oxy or other measure?
If I count the number of contractions here, I could see about 5 or 6 in 10. Yeah. If that is spontaneous, I might wait to see. But if this is driven by oxytocin, for example, I'll cut it back.
Ok.
Yeah.
Quindi in questo caso qua ridurre o stoppare l'ossitocina.
Sì, probabilmente noi non poniamo abbastanza attenzione.
Lei ha fatto un'idratazione alle 14, nel caso specifico è stata fatta idratazione con ossitocina comunque mantenuta. So is there something changing here or not?
Yes, the baseline is becoming a bit more stable now. I think that's the rationale for just waiting to see what happens. Because in the majority of cases, it corrects itself. But if you have other things like tachycystole in the background, or you suspect there may be infection, you do not want to continue to drive the labor while this is going on, because the baby then may decompensate.
So this fetus is now compensating
Yes, I think this
temporary hypoxia, maybe hypoxic stress or not?
No. Well, even if it is hypoxic, it's not significant hypoxia, because if it is, the CTG will look different.
Ok, quindi siamo tutti d'accordo che si va avanti, no? Questo tracciato. Alle 18:15 andiamo avanti, siamo ancora lontani. Vi ricordo che l'infusione, fra l'altro, è stata progressivamente aumentata e adesso è a 8 milliunità per minuto. 24 ml ora sono 8 diviso 3 sono 8 millunità per minuto.
Can I ask Austin if you would consider to reduce the oxytocin instead of going up with the oxytocin concentrations?
Yeah, I think um, we often drive labor just giving oxytocin to satisfy ourselves rather than worry about what's going on with the baby. As you know, oxytocin just doesn't increase the frequency of uterine contraction, but that's what we use to assess the effectiveness of our oxytocin administration. Oxytocin also increases the duration of the contractions as well as the amplitude of those contractions. So, for example, this woman's contractions actually last longer than 60 seconds. Yeah. Now, what that means is if she's contracting 4 in 10, the time available for the baby to reoxygenate and recover before the onset of the next contraction is very marginal. And these kind of babies will run into difficulty fairly quickly, especially if there are other antecedent problems with the baby. But if she's contracting 4 in 10, and each contraction is lasting 45 seconds, for example, or even 50, 60 seconds, for example, the time available for recovery before the onset of the next contraction is much better. And that baby's vulnerability to developing progressive acidosis is pretty small. So I think in the presence of any fetal heart rate abnormality, I'll be very cautious with increasing syntocin. And the other thing I tell people in my institution is examine women earlier when you start oxytocin, because some of them will respond to very low doses of oxytocin, and you don't need to increase it. But if you put up the syntocin and then come back in 4 hours or 6 hours, you would have increased it 6, 7, 8 times, when in actual fact you may not need to have increased it, and you may end up with toxicity of oxytocin. So I think in a situation like this where the CTG is not completely normal and we're using syntocin, what you want to do is to titrate the syntocin and give the minimum effective dose rather than just increasing it because it is time to increase it. Yeah.
Quindi il concetto qui è il discorso che probabilmente l'ossitocina è in overuse e che quindi dovrebbe essere, cioè gli suggerisce di utilizzare un protocollo comunque a basse dosi, anche perché di fatto non sappiamo se qui c'è qualcosa di antecedente. So now we are 5. Stop oxy. And this is the trace. Wait.
Yeah.
Commenti, cosa fareste o cosa avreste fatto al di là di stoppare l'ossitocina? Alle 18:15 poi vi dico la signora stava progredendo perché era sui 7 cm, quindi sta progredendo il travaglio. Quindi stoppate l'ossitocina con questo tipo. Sospesa infusione, ha già fatto il terzo carico di analgesia, l'idratazione è stata fatta in precedenza. 17:10.
La visita 18:15?
Sì, sto dicendo che il travaglio sta progredendo. La visita alle 18:15 non è stata segnata ma sta progredendo.
Ok.
Vi sto chiedendo cosa avreste fatto in questo momento.
Dico la verità, da noi saremmo andati in sala operatoria.
Potrebbe, visto sotto se la tocografia è attendibile, si può anche pensare a una tocolisi per un attimo di tempo e vedere come va la situazione. Questa è la cosa che farei. Per esempio, ma non so se sarebbe efficace.
Era normale. 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 temperatura materna normale, idratazione fatta, sospesa l'ossitocina, il collega suggeriva tocolisi, l'altra collega invece probabilmente con questo tracciato sarebbe andata in sala. Sì, sì, le conservative sono la tocolisi, idratazione, cambiamento della posizione. Prego? Sì. Sì, sì, ma di fatto idratazione, cambio, già fatto tutto. Ha già fatto stoppata l'ossitocina, idratata, cambio di posizione. E l'ossigeno è dibattuto perché le linee guida americane lo dicono, gli inglesi no. So someone is suggesting that to get oxygen to the mother. I know that American college is for and NICE is against, isn't it? Have you any comment on that?
I think the bigger point is the improvement in maternal oxygen tension, which you can translate into an improvement in fetal oxygenation, is so marginal that it's not worth the effort. I think that's so if you get mom to inhale 100% oxygen, it is true you may improve maternal oxygen tension. But does that actually enhance the oxygen delivery to the baby? And the answer to that question is no. The second point is a lot of these acute decelerations are in response to either cord compression or abnormalities of maternal placental blood flow. So even if you improve the oxygenation on the maternal side, the delivery to the baby is not
It's like nothing.
But for me, the more practical point is once people do that, they think they've done something and they're now helping the situation. And it stops them from taking the necessary step to do what they need to do, which in itself can be more harmful. So I think because its efficacy is poor, because most of the time the mechanism for the deceleration prevents the passage of that oxygen anyway. And thirdly, and most importantly, because once you start doing that, your mind is, oh, you've done what needs to be done, and then you're waiting for it to take effect when you should be doing something completely different. So it's not something that I advocate, and I don't think it's effective anyway.
Would you consider delivering these fetus?
Well, I think the first thing we need to recognize is that this looks like it is the oxytocin that is causing it. So if you look at the toco channel, you can see that the amplitude and the baseline of the uterine tone is gone up. In fact, you can almost make a correlation between the increase in the frequency and union of the contractions and the trajectory of the fetal heart rate. Sorry. So what I'm saying is if you look here, these contractions, by the time you come to this point, is much more prolonged. At this point, the baseline uterine tone is risen from here to here, suggesting that the relaxation time from the baby's perspective is almost now eliminated. And this is the fetal response. Can you see that? Now, if I was looking at this CTG in real time, I would be very worried at this point because this fetus has now not just, decelerated, but also lost variability. I wouldn't have seen this recovery when I was here, but it is possible that this could have stayed down as well. So personally, at this point, I would be thinking at least stopping the syntocinon, giving tocolysis if this persists, and if I'm not winning, to consider delivery. If I see this, well, that is good news, and then I will see, whether it recovers and whether the recovery is adequate. If it recovers with ongoing reduced variability, yes, I will deliver. If it recovers and the variability goes back to this, I'll wait until the CTG post-event looks like this, and then one can start again. But this is a worrying sign. Every time you have new onset loss of baseline variability, that suggests fetal decompensation or increased risk of fetal injury. Yeah. But the misfortune is, it sounds like something that we created ourselves. I think that's the.
Quindi è chiaro il discorso è, benissimo, stop l'ossitocina, eventualmente se non si risolve utilizza la tocolisi, quello che preoccupa è la riduzione della variabilità, se questa persiste immediatamente espletamento del parto. Siete tutti d'accordo? So this is a compensatory
Tachycardia.
okay.
Yeah.
Now the trace looks normal, isn't it?
Mm-hmm.
So in the suspect, looking at the meconium and the type of trace, antibiotics was injected. Do you agree about that, or there is no space for that? È stato somministrato l'antibiotico nel sospetto che ci fosse qualcosa di infettivo sotto.
We don't give antibiotics for meconium, but I'm aware that there are actually very good RCTs that show a decrease in chorioamnionitis and improved neonatal outcome if you give antibiotics. My problem is how those antibiotics actually work, because I don't know of any antibiotic formulation on the market that can cross the placental barrier in sufficient concentrations to eradicate infection on the other side of the placental barrier. But I suspect what may be happening is the fact that, as we discussed earlier, there's a very strong correlation between the presence of meconium and infection. Therefore, the contribution of morbidity from the infection might actually be what is making the difference, rather than anything to do with meconium itself. So at least in some subset of babies and in some types of infection, it may well be that administration of antibiotics at least delays the progression of the infection or modulates the fetal response to that infection. Some antibiotics clearly have anti-inflammatory properties, and we know that the thing that does the damage to the baby is not necessarily the infection itself, it is the host response. Mm-hmm. So if you can dampen down that host response, you may improve outcome, rather than the fact that you kill the bacteria that is causing the infection, and therefore you improve the outcome. I don't think anyone knows the answer, but in my institution, we certainly do not introduce antibiotics.
For meconium in itself.
Meconium, yeah.
Avete capito tutti il discorso? Ok. 18:15 la signora è a 7 cm e riprende l'infusione ossitocica. So as 6 p.m. the cervix dilation is 7 cm.
Okay.
And there is starting again for oxy.
Okay.
Alle 7:22, 7:22, stop oxy. The temperature is 37.
Mm-hmm.
Restarted again. Oxy at 9. This is a hyper response to oxy, isn't it? Or
Yeah.
so in this situation, it's better to use low dose scheme of induction of infusion. That or what do you suggest in this case? Because you are in the middle. It's 70 centimeters.
Yeah.
The response is not perfect.
Yeah.
What is your suggestion in this case to avoid oxy and to take your time and see,
Yeah.
or going on with oxy, looking at the right dose to avoid hyperstide stimulation?
Yeah. I think the problem that the team has is what dose of oxytocin is effective to drive this labor without compromising the fetal condition. And you can see that every time they start the syntocinon, once she begins to contract or the uterine tone goes up, the fetal heart rate deteriorates. We're just in the process of trying to bring in amniotic fluid lactate assessments to try and outline those women who are likely to respond appropriately and adequately to oxytocin infusion, and therefore use oxytocin in that group, and separate out the ones that are unlikely to respond, or you may just end up annoying the baby, or dragging the labor too long and then ending up with PPH and all sorts of things. So personally, I think that is probably what we need to be thinking about, because clearly in clinical practice, we do come across this subset of labors where you give syntocinon, the baby decompensates. You take out syntocinon, the labor stops, and you're stuck in the middle. At 7 centimeters, if there are other risk factors, I might actually think about going ahead with the delivery. So for me, things like infection, meconium, maternal pyrexia, requirement for oxytocin, and perhaps combination of these factors will make me think at 7 centimeters, maybe I'm better off delivering the baby. If I don't have those factors, there'll be some rationale to just wait, rehydrate mom, and maybe start the syntocinon at some point in future, but at a much lower dose, and see whether mom responds. Now, the point I was making earlier on about amniotic fluid lactate is, if you have access to that sort of technology, it allows you to determine whether this woman is actually going to respond to syntocinon at all, or do you need to give her some time, rehydrate, wash out some of the lactate, and then start again. It's a judgment thing, and every case is completely different.
Are you using your department this type of subsetting for lactate evaluation?
Not yet, but we're hoping to start in the first quarter of next year.
Avete capito il discorso? Lui va a distinguere sulla base della risposta miometriale, va a distinguere le donne anche sulla base del lattato a livello sostanzialmente locale, che può interferire con il tipo di risposta miometriale, anche l'ossitocina. Quello che lui dice è che se ci sono dei fattori di rischio, e nel caso specifico ce ne sono più di uno, quello che dice è meglio andare avanti e quindi vedere di far nascere questo bimbo, altrimenti di prenderci, Federico, dimmi se c'è qualcosa che di errato nella mia traduzione, perché il mio inglese non è perfetto, altrimenti se non c'è rischio infettivo in particolare, quello che lui dice, ok, benissimo, idratazione e riprendere cautamente l'infusione ossitocica, perché c'è il tempo per... So, what do you think about to deliver the baby? That means if you have this risk factor, you are saying that you have to go for C-section or to carry on with the labor?
No, you have to do cesarean. I will do cesarean.
Cesarean section, okay. So in this case, 7 centimeters here.
So
No, my question is, because we are discussing about from here, okay? From here,
Yeah.
okay. So if I have this type of trace,
Yeah.
I 7 centimeters, I go for C-section.
No, what I'm saying is, number one, every case is different.
No, we are discussing about this case.
Yeah. So that's going to be my next point. In this case, the problem you have is every time you give the syntocinon,
Okay.
the fetal heart rate decelerates. When you stop the syntocinon, she does not progress.
Okay.
So the point I was making is, if it is possible to work out the minimum dose of syntocinon at which she can progress without distressing the baby, then that is the way to go.
Okay.
But if you can't, you have absolutely no option, especially if there are other background risk factors. Yeah, that's what I'm saying.
Quindi se non c'è la...
But I think if I interpret correctly, I mean, time and progress is an issue. I mean,
Yes.
despite everything, she ruptured membranes, she started 1 centimeters, and despite stopping many times of oxytocin, at 6 o'clock this woman was 7.
Yes.
So she was actually progressing.
Yes.
My interpretation of what Austin is saying and what I would probably be doing, I mean, if you don't have too much contractions, this trace is normal.
Yes.
So why not to stop oxytocin and wait 2 or 3 hours or something like that, as long as the trace is normal, to see what's going to happen.
Yeah.
Of course, if the labor does not progress at all, you're a little bit stuck.
Yes.
But you don't need to make a decision just soon after stopping oxytocin and if the trace is back to normal.
Yes.
So
Yeah.
that's the point,
Yeah.
I think.
No,
Time to start again oxytocin.
Yeah, I mean, what you're saying, I mean, start again does not mean...
Find the same trace of the baby.
Yeah, probably, but they stopped oxytocin, waited for an hour, maybe there was no progression, no contractions, and then started again oxytocin. If the trace is normal, if you're don't have any major worry, why not to wait 2 or 3 hours to see what's going to happen? Because maybe that woman is going to start labor and progress in labor, even with not so many contractions, because she's 7 centimeters now.
Yeah.
Poi c'era anche il collega che voleva fare una sezione.
Monica, just before you hand the microphone, hold on. Were you in Dublin when they were using amniotic fluid lactate? And do you have any sense of what
the research was just published, yeah. But I know the background of the research, the idea behind it is very, very interesting. Yeah.
Because just talking to Robson, I know at the end of the day they weren't particularly overwhelmed by their experience. But my understanding is he did actually refine their use of oxytocin in certain subsets of patients, and if anything, reduce the number of cases they were doing for failure to progress. Yeah.
I've never seen it used clinically, to be honest, probably because they just published the paper,
Yeah.
and probably that was before publishing the paper, but yeah.
Devi fare qualche commento, Monica, perché sennò c'è Paolo e poi il collega che voleva fare Paolo?
No, sì, volevo fare un commento breve. Per stressare quello che dice Austin. Il punto è che io credo a Austin sia scattato in testa l'idea di allarme su questo feto dall'inizio del tracciato. E perché c'era il liquido tinto di grado 1 e perché non era un tracciato completamente normale all'inizio. Abbiamo usato l'ossitocina, che è uno stress sul feto, e ogni volta che si usa l'ossitocina il feto risponde con delle decelerazioni. E il travaglio si sta prolungando. Ci sono un po' di segnali d'allarme e lui dice precauzionalmente, finché non abbiamo un test come potrebbero essere i lattati che ci dice se possiamo andare avanti perché c'è una speranza che l'ossitocina faccia partorire, dovremmo probabilonghi considerare il cesareo. L'idea di aspettare 2 ore prolunghi di altre 2-3 prolunghi di altre 2-3 ore l'attesa su un feto che non è completamente normale dall'inizio.
Ma scusate, quanti di voi con questo tipo, non sto dicendo il tracciato, scusate, forse io volo a un livello molto più basso, nel senso che vado sul discorso della variabilità, del tipo di decelerazioni, che frequenza hanno, quanta ossitocina sto utilizzando e sto valutando se il travaglio sta progredendo. Se voi mi dite che perché ho un feto che è a rischio e so che è a rischio, che ha il dubbio, ho il dubbio che abbia delle problematiche, quanti di voi sarebbero andati in cesareo prima? La domanda me la pongo, cioè me la pongo nel senso che, benissimo, questa è una metodica che ha dei grossi limiti, però perdonatemi, io mi chiedo allora se, quando bisognava andare in cesareo qui? Cioè, qui? 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 Sono d'accordo con voi che questo è un feto che è a rischio, eh? La donna è andata avanti con alti e bassi, è arrivata a 7 cm. Però il discorso che sta facendo Monica, che Paolo condivide, che questo è un feto a rischio, che sappiamo che è a rischio e quindi bisogna farlo nascere prima. Ho capito male?
No, no, sto
Scusa,
dicendo che
posso-
questa verrebbe descritta da Robson nella sua classificazione delle distocie come inability to treat.
Io volevo dire una cosa, capisco che stiamo facendo un corso di cardiotocografia, però vorrei calare il tracciato nel travaglio, vorrei sapere anche il partogramma, perché anche se il tracciato non è sicuramente un'indicazione a un cesareo urgente, assolutamente, ma mi sembra che siamo 12 ore lì. Sì, è arrivata sino a 7 centimetri, ma con questa ossitocina che togliamo, mettiamo, togliamo, mettiamo. Dov'è? A che livello è la parte? Che presentazione abbiamo?
Allora,
è un bregma, è una posteriore?
No, perdona,
è una...
alle 19, allora, lei è partita con un reperto molto sfavorevole.
Assolutamente,
ok?
un
Quindi la
centimetro.
fase attiva del travaglio di fatto non è 12 ore, ma di fatto lei è partita nel pomeriggio, quindi sono 5-6 ore di travaglio. Alle 7 di sera, ripeto, con un partogramma che comunque che entro la linea d'azione, e di fatto sui 7 centimetri cefalica a livello -2 e non c'è una malposizione. Questo è quanto.
Meno 2, quindi non ci fa pensare a una cosa imminente.
Ok.
Un tracciato che non è patologico, ma che non è neanche...
Normale.
Insomma, io onestamente, cioè, il punto è
Sì,
quando è che diciamo basta, perché non è che possiamo andare avanti e
no,
indietro.
ma condivido il discorso, ma se noi le prendiamo, allora, premesso che ci sia una progressione, no, perdonami, sto dicendo che premesso che ci sia una progressione, e di fatto, ripeto, la donna è nel partogramma entro la linea d'azione, premesso un tanto, quello che ci stiamo chiedendo, con questo tipo di tracciato, andiamo avanti o no? Se non c'è una progressione, concordo con te. Se però c'è una progressione della dilatazione, ok? Sapendo quali sono i fattori di rischio, alla luce di questo tracciato, io mi chiedo, vado avanti o non vado avanti? Non sto discutendo, sono pienamente d'accordo con te che un requisito fondamentale sia la progressione ma quello che dobbiamo porci nell'ambito di una valutazione interpretativa del tracciato è se con questo tipo di tracciato, valutando la progressione con tutti gli alti e bassi derivanti dell'infusione ossitossica, che concordo pienamente, Monica giustamente ha detto Robson la classificherebbe come inability to treat, cioè un feto che di fatto non tollera questa cosa. Quello che mi sto chiedendo è se ci sono gli estremi sulla base del tracciato di andare in solo operatore. Questo è...
Stasera dobbiamo cominciare a porci il problema.
Ok.
Vi dico, non andiamo di corsa, ma ecco, qua dobbiamo cominciare a porci il problema, secondo me. Poi alle 7...
Allora, quello che diceva, so we are discussing about the prerequisite is that labor is progressing, okay? And if the labor is progressing on the basis, considering only the CTG. So, is there an indication to intervene by cesarean section before here? My question is that.
No, I don't see an indication for. In fact, if you look at the CTG, if you look at just the CTG, there is hardly any indication for delivery on the basis of the CTG alone. The problem is whether you're progressing or you're not progressing. The point Fede was making is a critical one. And it goes back to what I was saying about finding the minimum effective dose to drive the labor without distressing the baby. So if the labor can progress without the requirement for oxytocin, we don't have a problem. This CTG is completely fine. There will be no need for cesarean section. If you need syntocinon, and every time you put in the syntocinon, baby is unhappy about it, and then you have to stop, and your labor doesn't progress. The question you have to be asking yourself is, well, how much longer am I going to do this? And the point I was making about every case is different is, if I have other things in the background, or a combination of other risk factors in the background, I will err on the side of caution. And I say that because half the time, it won't be people like you, like Fede, like Monica, or like myself, that will be managing these labors. They may just put up the syntocinon and leave it in the hands of the midwives, take off to go do other things, and before you know it, things may go wrong. So personally, I think if you need syntocinon to drive a labor where the baby is not tolerating the syntocinon adequately, and you have other risk factors in the background, and you're at 7 centimeters dilatation in a first-time pregnancy, my threshold for delivering those ones operatively is lower than other thresholds. So for me, it's not just about the CTG. I do accept that the CTG, with normal variability, after each deceleration, the baby recovers to baseline. The indication for delivery on the basis of the CTG alone is very weak. I accept that.
So I have a question for you, because cerco di interpretare anche la considerazione del collega. So, here, we don't know the outcome.
Yes.
Okay? If this baby is depressed at birth.
Yes.
Okay?
Yes.
The medical legal problem is high, the risk.
Yes.
In this context, do you agree about that?
Well,
so it's better to go for C-section?
No.
Avete capito la domanda?
You're right. We don't, at least I don't know the outcome. If the baby is depressed at birth, I want to know, first of all, I need to see the CTG just before birth, and I need to see the indication for the delivery, and I need to see the mode of delivery and whether that delivery was complicated or straightforward. Yeah? But if the CTG looks anything close to what it's looking like now, I can tell you that the depression at birth has nothing to do with intrapartum events. And that is a question for your expert witness to decide. It's one thing to say, oh, the baby is depressed. It's another thing to say, it is what you did or didn't do in labor that led to the depression.
sono d'accordo con Federico, nel senso che fermarsi e aspettare 2 o 3 ore in uno che dall'inizio ho pensato possa essere infetto, è chiaro che è un pregiudizio che mi porto dentro, ma se penso che c'è un'infezione che lavora, aspettare 2 o 3 ore, chiedo solo il tempo di andare più avanti.
Anche perché tutto quello che abbiamo precedentemente e arrivati a questo punto, io non so qua se questo bambino continuerà a compensare o se sarò costretto a precipitarmi. Potrebbe scompensarsi anche in maniera abbastanza
So
repentina.
we are discussing about. So Paul is saying that what you said before,
Yes.
that you are looking at this case as at high risk for at risk for infection, and there is prolonged labor, and so the right question is, do you consider, so if you have the case like this,
Yes.
not stan,
Yes.
not pH,
Yes.
we know that you are not the medium
No,
obstetrician,
I am below
but
the medium.
if you are in labor ward in 2 in the night, okay,
Yes.
this type of trace,
Yes.
looking at the previous trace,
Yes.
considering that you know that this baby may be infected.
Yes.
PCR 1.2, te la fracco, 1.2, 0,85.
Giampaolo, posso concludere
No, no,
questa discussione, perché la domanda che tu stai facendo, la risposta è chiara. Lui, dall'alto della sua esperienza, di uno che fa 8.000 parti all'anno e di pattern di un certo tipo ne vede, ti dice a quel punto probabilmente sarei andato in cesareo, non perché il feto è ipossico e non ti serve il pH e non ti serve lo stan, perché se tu fai un pH lì è normale, ma perché lui pensa che a quel punto ha sparato le sue cartucce, non se la sente di protrarre ulteriormente il travaglio su un feto che ha un po' di fattori di rischio e non risponde come vorrebbe all'ossitocina. Poi lui ti dice anche, ci sono 2 concetti. Il primo concetto è che quel feto lì, se è depresso alla nascita, non è depresso perché stava male a quel punto, né perché stava male dopo, né perché la variabilità è normale. Quel tracciato lì è il tracciato di un pH normale. Ma è un feto, questo qui, fragile, su cui lui non prolungherebbe più di tanto il travaglio, ma non perché, cioè, l'ostetrico medio non credo che farebbe lo stesso tipo di considerazioni se non guidato dalla paura. Lui lo fa guidato dalla lettura di tutta una serie di fatti.
Lui quello che ha detto in maniera, allora, se questo bimbo ti nasce depresso che non sa l'outcome, lui ti chiede com'era il tracciato prima, subito prima del parto, che tipo di parto fatto, perché lui lo stressa nei suoi. So you're stressing in your paper that we know only a small part of the type of injury for the baby, because there is a synergic effect of birth trauma or type of delivery that may worsen the situation of the baby.
Correct.
Quello che lui sta dicendo, io su questo caso qui vado con le orecchie, probabilmente ho capito male, però quello che ho capito benissimo, questo è un caso a rischio, lo porta avanti con molta attenzione tenendo in considerazione il tipo e il dosaggio di ossitocina, vedere come risponde, se va in inabilità cioè se il feto non è in grado di tollerarlo vado in sala operatoria, se me lo tollera vado avanti, dopodiché se questo feto mi nasce depresso, probabilmente non mi nasce depresso per come era il tracciato prima, ma mi nasce depresso per tutta una serie di altri fattori.
Posso dire un'ultima cosa e poi taccio. Al di là di tutto, io prima volevo dire, al di là anche del sospetto di infezione, comunque bisogna valutarlo clinicamente, al di là di tutto, perché non è che si possa andare avanti a oltranza. E poi volevo dire così un aneddoto su Austin, che è venuto a Cagliari e gli abbiamo sottoposto un tracciato a trabocchetto e gli ho detto questa è una listeriosi. Era vero. Il bambino era morto dopo qualche giorno proprio per una listeriosi. Non so come abbia fatto,
So you're looking at the
Certo, perché
sphere.
ne ha guardati tanti, cioè ha capito che esistono dei pattern. Purtroppo noi lavoriamo con dei numeri molto bassi che non ci permettono di vedere, e poi insomma non siamo concentrati su questo, non ci permettono di vedere quali sono i pattern.
Scusate, posso dare... Andiamo avanti così vediamo anche l'esito, perché a questo punto qua, no? Ok? So, so they are at the end. This is a final stage of labor. Sì, 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 sì. Final stage. Second stage of labor. Okay, and finished.
Okay.
So, and now we have the musician. Which is the outcome of this baby? The colleague says that in Cagliari you have the forecast of the baby, okay, for listeriosis. What is the outcome of this baby?
Okay, so if you go back to the CTG and I'll try and,
Yeah.
if you go back to the CTG, I'll try and so let me just see the end, the
Yeah.
last bit of the CTG. Okay. And what time was the baby born?
Is born at 11.
So the last
No, but sì.
the last CTG, the last segment of the CTG I saw was about 22:35. Yeah, where the baseline.
No, scusate, ho detto una stupidaggine, di fatto lei di fatto non era in espulsivo qua. This is not second stage, sorry. Here there is no second stage.
No, but what I'm saying.
7-8 centimetri. Dieci. So in this case, we opt for cesarean section because there is no progression on the basis of CTG. My question is that, considering what we said,
Yes.
what is the outcome of the baby?
Yeah, that's what I'm saying. That if you, the way I will try and work out what the outcome is, and these things don't matter if the baby recovered with a CTG like that, particularly with good variability. So since it's recovered to baseline, since the variability is maintained, since that baseline is stable, I would expect the gases to be normal. What I feel less confident about is in terms of the ABGAS and the neonatal outcome. And that is on the back of my suspicion that actually something else may have happened to this baby, which is why it had a baseline heart rate of 155 at 39 weeks and was decelerating even before mom was in established labor. So that can have an impact on the ABGAS. But in terms of the gases,
It's normal.
it will be completely normal or near normal, unless there was trauma at delivery. And that's why I was making the point, picking up on what Paolo was saying, that actually the only thing you can reliably comment on during labor is whether there was asphyxia or hypoxia or not. But these other things that can also cause fetal damage, you can't make comments on those based on your CTG. So the CTG I'm looking at tells me that in terms of management of hypoxia, this case was well managed. In terms of damage from hypoxia, that's very unlikely in this particular baby. But this baby may also be vulnerable to risk of injury from other causes that are not necessarily hypoxia
So
driven.
in your opinion, is this case at risk for meconium aspiration syndrome?
I would expect the CTG to be worse than what it is if this baby had had meconium aspiration syndrome, but I cannot exclude it. And I say that because if a baby had meconium aspiration syndrome many weeks before they are admitted in labor, sometimes the CTG looks normal or near normal. But if the meconium aspiration syndrome is something that has happened in the last few hours or in the last few days, the CTG quite often looks more pathological than we've observed. And it will include things like tachycardia, loss of cycling, and sometimes shallow decelerations. So this one doesn't give me the impression that there is meconium aspiration syndrome of a recent onset. But I cannot exclude meconium aspiration syndrome from a long time ago.
Okay. Do you think this baby is infected?
I think the possibility is there. If it's infected, it may still be an early infection or one that is limited to the placenta, maybe the umbilical cord. But I haven't seen enough to make me think that there is well-established fetal systemic inflammatory response. But I cannot exclude it. That is also possible.
È abbastanza mago però.
Posso fare un commento?
Dimmi.
C'è mezz'ora di tempo tra la fine del tracciato e il cesareo, e il parto anche. There is half an hour.
No, the trace in the theater was not given here. But
I
anyway,
think the last bit of the trace we saw was 22:40. So that's about 20 minutes before the baby was born.
and this is the outcome. Cesarean section for failure to progress and meconium type 3. Umbilical gases is normal, depressed at birth, and no signs of meconium aspiration syndrome. The baby was intubated but extubated after 3 hours.
Yeah. Did you send the placenta for histology?
Yeah, but then I have to have a look on the results. Facciamo ancora un tracciato. So this case is 36 weeks, the first pregnancy, severe preeclampsia, induced labor and epidural analgesia. Quindi 36 settimane indotta per preeclampsia severa. Questo è il reperto all'ingresso, quasi completamente appianata, 2 cm di dilatazione con la testa -2 e non è sacco integro. These are the CDG traces, and this is the trace. It's progressing too much. Anyway, this is the trace in between 2 and 220. 6 centimeters dilation, and the cephalic presentation, and some spontaneous rupture on membranes with the meconium 1. This is the baseline before. This is the baseline now.
Yeah.
There are no decelerations there,
No.
so that tachycardia could not be sort of hypoxic.
Yeah, I agree. And again, in the presence of meconium, raises all the echoes of, again, possible underlying infection.
So this baby is high risk because of severe preeclampsia, isn't it?
Yeah.
Okay. And this is the vaginal examination at 8 centimeters, and this is the trace. Avete commenti vostri da fare? Prego? No, no, no. No. Sì. Normale, controllata comunque. Anche se è stata indotta per una preeclampsia severa.
You said he had meconium, is that right?
This is meconium, yeah. C'è un incremento della linea di base. These deceleration are, so I am to be worried about this type of deceleration, the increased baseline, and this type of variability in between.
Personally, no, because those decelerations are uncomplicated, in the sense that they start and finish within 60 seconds. Agree the variability is reduced in this segment, but I want to see what the variability was before and the variability after. And the variability before was normal. Yeah, so at this point the variability was normal. So the subsequent reduction in variability, the question is this something that's related to the cycling process or not? But for me, one big question is, if mom has got severe preeclampsia, is the baby well grown? Or does the baby have some degree of growth restriction? And if the baby did, then that will have an impact on how we interpret the CTG, number one. Number two, I think 36 weeks is pretty early to be passing meconium. Yeah, unless there's something else in the background. For a Caucasian woman whose pregnancy is properly dated, I think I'll be asking questions seriously about the presence of meconium at 36 weeks. I think it carries with it echoes of something else operational.
This baby is, there is no mention about the growth by the clinician, okay? And there is induced labor by prostaglandins, but no oxy.
Yeah.
My question here is there the space for acute tocolysis? Or
Yes, sorry, this was also my question, because she's been progressing extremely quickly.
Yeah.
Because she comes from the 2 o'clock, she's 5, and by 3 o'clock, 3.5, she's 8 centimeters. Well, babies, this is preeclampsia. We don't know very well about the baby. Of course, there is a question point about infection, but could not just that be
Yes.
chronic
Yeah.
underperfusion? So
Yeah.
all these things, and we are also, we want to deliver the baby. We are stressing the baby a little bit too much.
Yes.
With that labor, which is going very, very quickly.
Yes. Yeah. No. I totally agree, and I think it goes back to the conversation we were having about the first case where syntocinon was being used. You can precipitate exactly the same scenario with prostaglandins, and you can exacerbate the situation with prostaglandins using adding oxytocin on top of it. I think it's well recognized that women who have preeclampsia, particularly severe preeclampsia, tend to labor quite forcefully and quite precipitously. So if we're inducing them, all the more reason why we need to use oxytocic agents very cautiously and very judiciously. So I totally agree. Rapid progression of labor for any fetus is a challenge. For a baby whose mother has severe preeclampsia, it's even a bigger challenge. And if that baby is also bearing some burden of morbidity from that preeclampsia, even more so. So I absolutely agree with Federico's point. The question of should we be using tocolytics at this point, I would think so. If anyone uses it, I won't criticize it, because again, the frequency of uterine contraction is just on the edge of what could be acceptable. But if it's distressing that baby, you've got to react. You've got to react to that.
so I didn't get you, because I think that now the baby, I may suppose that there is a placental insufficiency here. Okay?
Yeah,
And I have 1, 2, 3, 4, 5.
yeah.
So hydration may be cautious because the mother is in a severe preeclampsia, but pressure may be too high.
No, I wouldn't hydrate a severely preeclamptic woman.
Okay.
And I don't think that would change the CTG anyway. So I think the most reasonable option, given what we're observing on the CTG, will be tocolysis, yes.
Tocolysis,
Yeah.
ok. Siete d'accordo anche voi? Cesareo fatto alle 15:35 and this is the pH. So, and the baby as a small baby. No, it's not too much because it's not below the 10 centile, but it's a small baby and normal APGA score, but is close to metabolic acidosis, isn't it? So, we don't know, because in this case we don't consider tocolysis, because as Federico said, the labor was very, very fast. And maybe he was distressed by placental insufficiency and labor too fast. Maybe?
Yeah, well, the other thing to think about is a good number of these babies on the back of preeclampsia already are operating on the very edge of acidemia. And all you need is, a very forceful labor to tip them over. I think just looking at the CTG, I would not expect a pH of 7.02. I think that's, unless of course if there were other problems at the delivery. But 7.02 is quite low for this CTG and the duration of time that the CTG was the way it is. The other thing to think about is that base excess. If you look at the pattern of the decelerations on this CTG, in and of themselves, that's not enough to escalate the base excess to -8. That's quite, for the duration of time that the woman labored, that's quite a lot.
Because the baby is at risk. Because if you have a normal baby, the pH 7.25, isn't it?
Yeah.
Quindi il discorso che comunque i casi a rischio, come si diceva anche prima, rispondono in maniera totalmente diversa rispetto ai casi non a rischio. So this lady is 39 weeks, no risk, and admitted at 2 for spontaneous rupture of membranes. 2 centimeters dilated, spontaneous rupture of membranes, clear fluid, and this is the trace at admission. Admission at 1, 2, roughly. And the lady asked for epidural, and this is after hydration, and this is the trace after epidural.
Have you got a trace before this point? This one?
It's normal, isn't it? Otherwise, it's normal. Do you agree about that?
Yeah, it is. I'm just surprised that, again, I'm surprised at where the starting baseline is. And the next trace, the baseline is also, here. So this baseline is roughly about 160. And this is 0250. Can I just see the last trace?
So this is after, so 245 epidural, and this is the trace after epidural.
Okay, and the trace before, when did it stop? What? No, that's
40 minutes are missing, I'd say.
yeah. Okay. Yeah.
See. But anyways, it was like this. And this is the trace after the epidural.
Okay. Yeah.
So there is a very fast progress of labor, because 3:30 is the dilation was 9 centimeters,
Yeah.
clear fluid. Baseline is at the limit of normal.
Yeah.
It's 4, and this is the trace.
Yeah.
Are you worried about this type of deceleration?
Yes, I am. It's not just the I mean, these are complicated variable decelerations, but also the baseline from where you're getting the deceleration worry me even more. I think we have to take fetal heart rate tachycardia much more seriously than we currently do. Especially if you haven't seen that baby when the fetal heart rate was completely normal. Fetal heart rate tachycardia is a very sensitive marker of the need of the fetus to amplify his or her cardiac output. So babies don't become tachycardic simply because mom is tachycardic, or because mom is pyrexial, or because mom has got infection. Babies develop tachycardia because there's something intrinsically going on in those babies. So for me, the presence of tachycardia, even when they're not associated with deceleration, it's always a concerning finding, particularly when you make those findings in babies that are at term or near term. So I worry about the decelerations here, but I actually worry more about the baseline tachycardia. Now, if this baseline tachycardia was driven by intrapartum hypoxia, I would have expected to see more persistent and prolonged fetal heart rate decelerations to provoke it. But I really haven't seen it. So it makes me think, well, what else is responsible for the tachycardia?
So what do you think that the position of the head of the baby, like in OP, may influence the CTG trace?
OP is associated with a whole range of adverse outcomes, but so OP babies are more likely to have decelerations. I think that is well documented. But I'm not aware that OP in and of itself will be responsible for an increase in fetal heart rate.
Okay, so you're worried about that. What is your time decision for delivering this baby?
At this point in time, I'm not thinking of delivery for the simple reason that the baseline is pretty well established. The variability at that baseline looks normal. And if labor is progressing, I think I'll just intensify my surveillance, but I'm not thinking of delivery just yet.
So you're worried about the tachycardia, but the variability is normal.
Yeah.
And this is a good sign, isn't it?
Yes.
And we can carry on.
Yeah, personally I'll carry on.
Siete d'accordo anche voi? I commenti sono stati sulla cartella, decelerazioni variabili ripetitive con aumento della linea di base e variabilità mantenuta. Fatta idratazione, la paziente è in posteriore, la presentazione encefalica in OP, rivalutazione a 20 minuti, non è stata fatta tocolisi perché di fatto non c'erano contrazioni subentranti. And this is the trace after this. Is there a reduced variability here?
Yeah, there is. If you just go back to the one before, what time was that?
Again?
Is that 150 or 410, 415? Okay, then the next one. So okay, yeah. Okay, if you go to the one before that, yeah, next one.
So again,
Forward. Yeah. Okay. My concern at 4:30, the question I will be asking is, are you still monitoring the baby?
So there is no. It's a different, maybe a maternal pattern, isn't it?
That's possible, yes. In fact, that's quite likely, because how many centimeters was she at this point?
It's roughly at fully dilated. It's fully dilated.
Yeah. Given the progression of the CTG, I would expect the fetal heart rate pattern to worsen rather than improve. And at some point, at about 4:30 or just before, there's a sudden transition in the
Completely different.
Yeah, there's a sudden transition in the characteristics of the CTG. And I suspect that from about 4:29, 4:30, the fetal heart rate was being contaminated by maternal heart rate. And then if you go to the next frame, I think it is clearer now that actually most of what you're getting is probably maternal rather than fetal.
So we decide for operative vaginal delivery in a theater, and the baby was born at roughly 5 in the morning with normal Apgar scores and pH.
Yeah. But the real giver, the thing with if you pick up maternal heart rate, the problem you have is you don't know what the fetus is doing.
Yeah.
That is the problem. But clearly, in this case, the duration of time when we saw the baby's baseline heart rate to be fairly stable, although there's loss of variability, to when the baby was born, even if the baby was bradycardic, I don't think that's long enough to cause damage unless if the baby had other problems. But clearly, if the heart rate for that baby had collapsed,
We don't know.
you wouldn't know. You think you're still monitoring the baby, but that's maternal heart rate. In fact, I saw some accelerations that coincided with uterine contractions. I think that was maternal heart rate.
We go for the last case. Is NALIP 41+5, GBS positive, is low risk pregnancy, no complication during pregnancy. This is the first vaginal examination because GBS was the ampicillin was given, and dilation 3 centimeters, cephalic presentation -3. At 12:20, artificial rupture membran clear fluid, and start Sinto.
Just out of interest, why do you use ampicillin?
For GBS, we have our recommendation for because we start a label.
Yeah, no, but why ampicillin?
They use benzaprine. Usano la
So
second choice, probably in Italy we have more
cheap.
waste money.
Difficult to get penicillin because it's too cheap.
Yeah,
It's very difficult. Don't get it.
Yeah, I don't know why they've chosen instead of penicillin ampicillin, but I think it's quite
Tutti quanti ampicillina. Sì, quindi. This is an Italian problem. The cost is too low.
Yeah, I mean, in fact, I'm almost certain that the rest of the world use benzapenicillin as first
The rest
choice.
of the world,
Yeah. I think the Spanish probably use ampicillin as well. But the bigger point is you want to use the narrowest spectrum antibiotic for your group B prophylaxis. I think that's the bigger point. Now, all strains of group B strep are sensitive to penicillin. So giving ampicillin is fine as far as efficacy is concerned. But because ampicillin is a broad spectrum antibiotics, you may end up, killing other bacterial species that are not necessarily group B strep. And that may have an impact on how the baby's immune system is educated at birth. And all sorts of noises are being made about the link between the microbiota that the baby sees at the time of birth and how the immune system is educated, and the risk of allergy, childhood asthma, and all those sorts of things. So what you want as a matter of policy is to use the antibiotic that interferes with the maternal microbiome the least possible. So I was just interested that if you have a policy of giving ampicillin to nearly 20-25% of your pregnant population because of GB colonization, that may have an impact on even at on a wider scale, antibiotic resistance in the community.
So anyway, this is a political problem, and this is the trace, and there is very fast. So consider that there is 3 centimeters as roughly 12, and roughly 5 p.m. we have 7 centimeters dilation, clear fluid. And these are the traces in between 5 and 6:30.
Yeah.
It looks normal, isn't it?
Yeah.
And roughly a 6, the dilation 8 centimeters. This is the pattern of contraction, and this is the pattern of CTG trace.
Yeah.
The cervix fully dilated, then there is the beginning of second stage.
Again, my question is, are you still monitoring the baby?
I don't know. Avete commenti voi da fare qua? No, non facevo ossitocina. Se scusa, ossitocina non l'ho segnata, però di fatto è una considerazione più che giusta, che in tachisistolia. Siete d'accordo?
Scusate, commento dal fondo, è una 3D PCAR o stiamo monitorando la mamma? L'ha accennato prima Giampaolo, per vari motivi in Italia la classificazione di PCAR è molto di moda in questo momento. Va presa un pochino con le pinze per una serie di motivi. Il primo che ha accennato è che il lavoro originale è un'esperienza limitatissima di un centinaio di travagli. In letteratura il lavoro di Picard dell'88 ha 20 citazioni, pochissimo, non se lo fila quasi nessuno. L'altro problema di base per la nostra esperienza è che il lavoro originale è fatto con l'elettrodo su scalpo e appena citato il pattern 3, che è un pattern riferito nel lavoro di Picard terrorizzante su non si sa quanti casi, molto pochi, associati da un negativo, è quello con le accelerazioni fetali durante la contrazione. Nelle nostre sale parto, dove nella maggior parte dei casi utilizziamo il trasduttore a ultrasuoni, la causa più probabile di vedere un'accelerazione durante la contrazione è che in realtà si stia prendendo il tracciato materno. Sono due lavori fatti benissimo, uno ancora fatto da Arul qualche anno fa e un altro lavoro replicato da Aires do Campos, monitorando contemporaneamente con l'ultrasound e con l'elettro su scalpo il problema del tracciato con gli ultrasuoni e che sovrastima le accelerazioni e sottostima le decelerazioni, perché molto più spesso prende il battito materno. Questo è, scusate, è una puntualizzazione perché ho sentito un commento. Quindi quando parliamo di PICAR 3, attenzione, perché dobbiamo davvero essere sicuri che sia il feto, più spesso è la mamma.
Concordo pienamente con quanto ha detto Fede, e questo è l'esito. pH less than 7, quindi questo è stato monitorato di fatto, lo so per certo perché ne so per certo, è stato monitorato la frequenza cardiaca materna.
Austin, can I just ask you if you always monitor maternal and fetal heart rate together when you use the external transducer?
No, we don't. My hospital is fairly unique because we use internal monitoring very frequently, even for ordinary CTG, and that is because, unless of course for people who have contraindications like HIV, hepatitis, and those sorts of syndromes. But because we use ECG, it just means that most of our machines operate, they acquire the signals via an internal electrode. So we don't have this problem of ending up monitoring the mother as frequently as we observe in other units. Now, having said that, a lot of the newer CTG machines have channels for maternal heart rate monitoring. So you can see the two printouts, running concurrently.
Perché nel posto dove lavoro io in Irlanda sono sempre monitorate le due frequenze cardiache. Io credo ci siano due cose che non monitoriamo molto bene qui in Italia. Una è la frequenza cardiaca materna e l'altra sono le contrazioni.
I do agree. Andiamo con l'ultimo, abbiamo 5 minuti, 5 minutes before lunch. This low risk pregnancy, 39 weeks, and is a multiple.
Sorry, Gianpaolo. I was just going to say that my advice to anyone who is engaged in this business is, if you are not sure what you're monitoring, just put a scalp electrode. It's not worth just put a scalp electrode on.
Yeah.
And that will clarify the diagnosis.
So it's an obese woman.
Exactly.
If you have any doubt.
If you have any doubt, just put a scalp electrode on.
Quindi c'è qualsiasi dubbio è meglio monitorarla da scalpo. Allora, questa è una donna a gravidanza a basso rischio, alle 2, questo è 2 di pomeriggio, questo è il tracciato, 2 cm di dilatazione, membrane integre, contrazioni spontanee, dilation, dilatazione 3-4 cm, le contrazioni sono frequenti, contratto però normale. There's a normal trace with spontaneous contraction. There is no indication for tocolysis, isn't it?
No. If there is no fetal heart rate abnormalities, we tend not to give them tocolysis, even if the contraction is 8 in 10.
But if you are using prostaglandins,
Yes.
if you have tachysystole, if you have a normal trace,
Yes.
are you using tocolysis or not?
No.
You remove the disposal or not?
Some people do, but if I don't have fetal heart rate abnormalities, I tend to just wait, yes.
Voi cosa fate? Rimuovete o... Perché se voi guardate la linea guida dell'ACOG sulla tachisistolia, no, ti dice di rimuovere il dispositivo e di fare tocolisi. No, ma è una linea guida che di fatto è riportata, no?
Sì, ma se il tracciato tiene, va tutto bene, se è a basso rischio...
No, sto parlando, ci siamo persi. Io ho fatto una domanda diversa, non sto parlando del caso specifico. La domanda che io le ho posto è: se c'è una donna indotta con prostaglandina, mi va in tachisistolia, però il tracciato è normale. Rimuovo la prostaglandina, il propes per intenderci, o vado avanti. Ok, la linea guida dell'ACOG, se non sbaglio, ti dice di rimuoverla e di usare la tocolisi.
Non so se io utilizzerei come criterio anche dipende dal grado di distress della donna, perché puoi avere contrazioni da prostaglandine che sembrano essere molto frequenti, ma magari causare, e donne che sono in travaglio sparato. Sì. Are you not? Which are your reasons for removing propes? If the woman is distressed with 6 contractions in 10, but the trace is still fine, would you remove it?
I'll give her painkillers. I'll give her analgesics. Yeah.
So you remove propes only if there is a CTG abnormality?
Yeah, fetal heart rate abnormality is what translates tachysystole to hyperstimulation. So if all you have is a tonic uterine contraction or frequent uterine contractions, but you don't have fetal heart rate abnormalities, then they are what they are. A large number of those will just peter away over time and don't need any other intervention. But you may find a situation where you don't have tachysystole, but you have fetal heart rate abnormalities. You have to take out the prostaglandin under those circumstances. So for me, the thing that changes the picture is fetal heart rate abnormalities. If, as you say, a mom is intolerant of those contractions, it's a judgment thing. If I examine her and actually the cervix is now effaced, membranes are bulging, then she doesn't need the prostaglandins. I'll take it out under those circumstances, maybe offer her analgesia. But if I still need the prostaglandins to alter the Bishop score and there's no fetal heart rate abnormality, I wouldn't take it out. In my view, I think it just interferes with the induction process. If there's fetal heart rate abnormality, I'll take it out. If the CTG doesn't improve, I'll give tocolysis. But for me, the guide is fetal heart rate abnormality.
So we carry on with the case. As this is the hour, 5 centimeters internal membranes, and the lady was using spinal analgesia, and this is the trace. This increased tone, uterine tone,
Yeah.
and this is a trace.
Yeah.
Low risk, 5 centimetri, il collega anestesista ha fatto una spinale e questo è il tracciato. Are you worried about that after spinal analgesia?
A lot.
A lot. 5 centimeters, qual è in questo caso cosa 5 centimetri. Low risk.
Well,
So, this is the vaginal examination,
yes.
8-9,
Yeah.
okay. Spontaneous rupture on membranes, clear fluid done,
Yes.
and transfer to the theater.
But why did it happen? Why did the fetal heart rate decelerate?
Because they are spinal. Is the spinal here?
You mean spinal or epidural?
No, spinal. La spinal.
Why spinal?
Because the anesthetist went for spinal. I do agree about that, but anyway, we know that spinal is associated with the higher risk of this type of traces, isn't it?
No, the reason I'm asking is I'm struggling to make a link between the
Spinal?
yes, I'm struggling to make a link between the spinal and the uterine hypertonia.
If you use sulfentanyl,
Yes.
and and the type of analgesia,
So
there is
that causes uterine contraction.
yeah,
Okay.
and reduce blood flow in the uterine
Okay.
arteries.
No, I didn't know that. the few times I've come across this situation is when they give an epidural top-up or a spinal in theater, and then they increase the fluid to correct maternal hypotension. But that fluid also carries the syntocinon channel. And then they flush in the syntocinon as a bolus. And that creates the uterine contraction, and then the fetal heart rate, drops.
But it's not the case.
Yeah, well, I'm just saying, that's one scenario where I have come across, this sort of situation. So the problem for the baby is not so much the spinal or the epidural or the medications used. The problem for the baby is the sudden infusion of syntocinon that was in the tube.
But we are, cioè lui dice che sta dicendo che il problema è l'idratazione sul stesso accesso venoso in cui c'è l'idratazione e anche l'infusione ossitossica. No, we are not using, so we start.
No, I'm just making a general,
Okay.
because
A consideration.
we use epidural a lot, we use spinal a lot. We often see babies' heart rate drop when they put spinal or when they put epidural top up. But we don't often see an increase in uterine contraction. We don't, it's for me, it's a new observation, which is why I'm commenting on it.
No, in our setting is quite so often. And this is so we transfer the lady to the theater.
Yeah, Gianpaolo, just wondering, this
Yeah.
probably is not the case. One other possible explanation, in Italy we have very much the habit, while someone is examining the woman, particularly the doctor, you're very much accustomed to have the woman in letotomic position and
Right.
supine.
Right.
So this may not be the case,
Yes.
but sometimes you have an indication to perform an examination,
Yes.
and maybe the heart rate trace is already struggling a bit,
Yes.
and then because of the habit, you put the woman in supine position,
Yes.
which is the worst thing to do
Yes.
to improve
Yes. Yes.
placental
flow.
blood flow.
Yes.
And sometimes it also affects the baseline of the toco, so you see a change in the intensity of the contraction, which is not really
Yes.
a change in intensity, but just the toco is displaced in a
Okay.
different way, so it records in a different way.
Okay.
Maybe this is not the case, but it is
In
another
in
explanation.
this case, we have the vagina examination because of deceleration, and we don't know about how long is the deceleration. And this is the trace after hydration in the theater.
So, sorry, can I ask to Austin this question? Because I presented the same trace by talking about bradycardia, and I think that bradycardia can recover. But what do you consider as normal, for a trace that has recovered after bradycardia? This is not a normal trace. you know? So, what's your management when the trace is going back but not to a normal trace?
My management is to wait until the subsequent trace looks like a mirror image of the trace before the deceleration.
So in this case, the trace before deceleration was the prolonged deceleration was normal.
Yeah.
Is a low risk pregnancy,
Yeah.
and this is the trace after,
Yeah. That looks different.
and that's the point.
Yeah. So
It's a normal trace, as Monica said. So it's a normal trace.
yeah. So
Is the baby is distressed? Is already distressed?
well, if
Maybe.
but if it is distressed and you haven't relieved that distress, the fetal heart rate will not recover. So the recovery suggests that the distress, if I may use the expression, is being relieved and is not, sort of, cascading or increasing. The problem you have when this sort of thing happens on the edge of second stage or during second stage is quite often the distress is not relieved because the uterine contraction increases in frequency, in strength, and in duration, and maybe mom is pushing. So baby will have a completely different experience. But for me, if the baby recovers from the deceleration, what I would like to see is that the CTG looks similar to what it was before the deceleration. If it doesn't, what should be left is just, the consequences of that deceleration, and that should be just the post-deceleration tachycardia, rather than things like loss of variability or deeper
This,
deceleration.
like this.
Yes, yeah. So,
So-
what you have here is post-deceleration tachycardia, but it's also now got decelerations as well. So the judgment you have to make is whether these decelerations are in relation to her entrance into second stage, as well as the tachycardia after the deceleration. And what does that mean for you and the woman who is going into
But
second stage of labor?
with this type, so this is a compensatory effect.
Yeah,
Okay.
yes.
But anyway, the CTG is not normal
Yes.
at all. So this baby is at risk for metabolic acidemia.
I will go for respiratory acidemia first before talking about, because if the heart rate, in this baby, the heart rate dropped to about 60, 70 for maybe about 8-9 minutes. The amount of carbon dioxide that the baby will accumulate over that sort of time is likely to give that baby respiratory acidosis.
Acidosis.
And the increase in baseline heart rate is actually an attempt by the baby to get rid of all of that carbon dioxide. But I suspect because the baby is also going into second stage, then you are getting the decelerations as a consequence.
Okay.
Yeah.
Austin, sorry, how long do you wait with a trace like this? Because, here there is, variability is reduced, there are deceleration, the baseline has increased, so, how long would you wait? And there was a bradycardia before. It was a perfect trace to start with, but
Yes.
then a bradycardia, and then not a normal trace, and then
Yes.
again, how long do you give to yourself, you know?
It's easier to answer that question in the first stage of labor, because in the first stage of labor, the stress on the baby is less than in the second stage of labor. So most babies that experience prolonged bradycardia in the first stage of labor will recover with some tachycardia. Now that tachycardia tends to resolve within about 20 minutes, mean time for most of them. The ones that have other problems, you may not see the recovery over that time period. If they have abnormalities on the CTG before the prolonged deceleration, quite often it takes longer than 20-30 minutes before they settle. So that situation is completely different. The ones that are difficult to guesstimate in terms of how long you wait are the ones that happen in the second stage or on the edge of second stage. And I think what is happening is, on top of that bradycardia and the recovery, the baby is now facing the additional insult of the events that happen in the second stage. Personally, what I tend to do is just follow the baseline and follow the variability. And in this case, the baseline, although is up, but it's not increasing. The variability is reduced, but I don't see any other, ghastly things on the CTG to make me want to intervene at this point. So on this case, I will still wait and just continue to monitor. No, I wouldn't.
So we go to finish because we are late anyway. This is the outcome. Normal was normal. At the end we had roughly normal variability.
Yeah.
And the baby was normal at birth.
Yeah.
Signori, siamo in ritardissimo. Vi ringrazio per l'attenzione, siete stati molto partecipanti. Speriamo di vederci.